Thank you very much. It's a real honor to be here. Really like to thank the organizers of this meeting for the opportunity to come speak with you. And I'm going to speak this morning for 20-25 minutes about the question of understanding ICU bed strain. Now, I gave a version of this talk maybe a year ago and had entitled it Understanding Bed Pressure, and I got a lot of questions asking if I was going to talk about bed ulcers and that aspect of bed strain. But no, I'm actually going to talk about something that I think another issue we all deal with in the ICU on a regular basis, the issue of feeling under strain and taking care of patients. I should mention I don't really have any conflicts of interest. I am, as mentioned, an associate editor for the American Journal of Respiratory and Critical Care Medicine. I do have some research funding for unrelated topics from various Canadian institutions. So in terms of understanding what people think of when you say bed strain or capacity strain, it turns out that not everybody is focused on the exact same thing. This is a study that was done in the United States by a group at Pennsylvania, where they were asking physicians and nurses when they felt that they were under strain and what were the aspects of what was going on around them that caused them to feel that the ICU was under strain. And what they found was that, in fact, when they asked charge nurses, there were a bunch of different issues that came up that made them feel strained. The actual census, in this case it was a medical ICU, a MICU, the Apache 3 score, so the severity of illness, the number of new admissions, and the census on the general medical ward. And interestingly, the physicians were a little less sophisticated about it and found that only the MICU census seemed to be their focus in terms of whether or not they felt strained. But the study is nice because it kind of teases apart some of the different aspects of what is meant by strain in the ICU. And I'm going to spend the next part of my talk taking you through the fact that I think you can kind of unbundle but also recognize that these things go together. The fact that the number of beds you have and how they're being used creates strain. The patient acuity in the unit creates strain. And then I want to talk a bit at the end about staffing and how you staff your unit may also induce a sense of strain. So starting out with the issue of beds. So the question of beds and how many beds you have and you're working with can be seen at both the ICU level, the hospital level, but also at the national level. And we've done a fair amount of work trying to get a sense of just how big the variability is in terms of ICU beds, in this case, per capita or per 100,000 population. And you can see, just casting your eyes over this graph that quantifies across a bunch of different countries, that there's a lot of variation going on here. So the United States, where I used to work until a few years ago, is about 20 ICU beds per 100,000 population. I have New Zealand on here. It's down at about 5 ICU beds per 100,000. And the UK has gotten a little better since this graph was published, but down about sort of 4 or 5 as well. And from my back of the envelope calculations this morning, based on data on the web, I would say Singapore is closer to the United States. My calculation was around sort of 17, 18 ICU beds per 100,000. Perhaps some of you can tell me afterwards if I'm near the mark. But it gives you a sense of just how different in a system that you're working in you might find ICU bed availability. And we've looked at this across the US, and what I call here, and I put it in quotation marks, a system of 97 US ICUs. This is project impact data, and the reason system is in a quotation marks there is it's not really a system. This is 97 ICUs across the country, so they're not exactly transferring patients between these hospitals. But we took all of those ICUs, we combined them and said, what if they were sort of one giant available ICU, and what was the occupancy overall across the US in that regard on an hourly basis over 3 years. And what we found looking, this is 2005 to 2007, it maybe has changed a little bit since then, but not much, is that if you look at this, it's first of all pretty constant over time. You know, this is smoothed out, but you get a sense there's not massive perturbations in the system. And we also found that only about 20 to 30% of patients in ICU beds, or sorry, only 20 to 30% of beds that are, of all ICU beds have a patient who is mechanically ventilated, which is really traditionally what we think of when we think of an ICU patient. And at any given time in the United States, 20% of ICU beds are available. Now that is of course not to say that in your ICU there's always 20% of the beds available, but when you think of it at that level and the kind of strain on a system, you can see that overall the United States is a relatively unstrained system. Now you can contrast that just by looking at overall occupancy with a place like England, where I showed you of the very few beds. And you can see here the bottom part is the US in terms of the overall occupancy, and then that top line is the overall occupancy in UK ICU. So you can see right there that the occupancy is quite different in these two countries. And so your experience of caring for patients working in these different systems is going to be quite different. Now, as I mentioned, having an overall occupancy doesn't tell you anything about your own ICU. So we looked at those 97 US ICUs I showed you, and we broke it apart. Each of these vertical lines is an intensive care unit, and the occupancy by hour of the day over 3 years. And so you can see these hospitals here, these ICUs, basically all the time have 4 or more ICU beds available. They are an unstrained system from the ICU bed capacity perspective. And then, not surprisingly, even in a relatively unstrained system, we also do have ICUs where there's substantial strain, where in the black hours there, almost 50% of the time, they're operating at an occupancy of 100%. So you can see, of course, not surprisingly, that the individual hospital and ICU you work in will have a large impact on that as well. One example of how unstrained a system can be is this is the Veterans Affairs system, and for those of you not familiar with it in the US, it cares for the veterans in the United States, and it's one of the few kind of single-payer systems because it's government-run. And this is a study that looked at patients coming into the emergency room across all of the VAs in the United States. And what you're seeing on the x-axis is their predicted risk of death on admission in the emergency room. And then each of those lines is an individual hospital. And for each predicted risk of death in that hospital, what percentage of patients were admitted to an intensive care unit. And the bottom line, it's kind of a hard graph to wrap your head around, is they found that 53% of the patients admitted to the ICU from the ER had a predicted mortality of less than 2%. And so I would argue you have to have an unstrained bed situation in order to do this, because those of you who work in a more strained system would know that, of course, you wouldn't even consider admitting most of those patients to the ICU if you're reserving them for the patients you feel really need those beds. If you look even within, again, the US, this is data from Chicago, where they do have a lot more strain than, say, the VA system, they were trying to actually understand what does this do when you are in a strained situation. And so they looked at what they called the opportunity cost of futile treatment in the ICU. And what they did is they decided, it's a slightly strange definition, but I'll show you in a little bit why this is actually realistic. They called their unit full when there were less than 2 available beds, so either 0 or 1, which sounds a little funny to say if you have 1 bed, you're full, but in terms of queuing theory, I'll show you later, this is actually pretty realistic. And so they looked at when their different ICUs were full and how many days that happened. And you can see across here, a lot of days their ICUs were full. And then on those days that the unit was full, they asked the physician in the unit to say, do you feel that 1 or more of your patients is currently receiving what you would consider futile care, meaning it is not going to lead to them getting out of the ICU? And it turned out that particularly in their medical ICU, that top line there, 86% of the days the unit was full, at least 1 patient in the physician's perspective was receiving futile care, meaning that bed was being taken up by someone where people felt that it was not going to benefit the patient. And then they looked upstream from that, and they said, okay, well, so we have futile care here, and we have no beds available. What is that actually doing in terms of our care for patients? And they looked in their emergency room and quantified how many patients were waiting for a bed for more than 4 hours at the same time that they had that full unit. And sure enough, particularly for the medical side, they found that 19 patients in this study were waiting more than 4 hours. Now, of course, that wouldn't matter if it didn't make any difference to care, but we have a number of studies that suggest that delays in getting to the intensive care unit really do impact outcomes. This is one example from René Robert in France. This is a study from Paris, tracking patients on the wards who were being assessed for admission to intensive care. And if they were admitted immediately, that top line, there's still a substantial mortality for all of our ICU patients. But if they were admitted after what they called bumping of another patient, meaning they had to wait for a bed to open up, you can see that's this line here, and you do see an increased mortality associated with that waiting experience. Now, in terms of thinking overall about this model of flow associated with your beds, it is important to recognize there's a lot of different factors, not just what's going on in the ICU. So in terms of thinking about where our patients are coming from, most of them come from the ER, the ward, or the operating room. Some are maybe coming, what I call here, OSH, outside hospital. That's apparently an American phrase. And so, of course, if you have the downstream where patients generally are either going to a ward or they're dying. That's your sort of flow pattern of patients in and out of the ICU. And so to conceptualize, when you think about that availability of ICU beds, you're going to feel strain if either you have a massive increase, sort of a surge in terms of the need for intensive care. You're going to have strain in terms of ICU beds, as I showed you, if, for instance, you're providing inappropriate care for patients in the ICU or you just don't have enough ICU beds. But it's also important to recognize, and this is happening more and more in places like the US, if you don't have enough ward beds, you can have an entire backup of the system and create a strain purely because you can't get your patients out of the ICU. So that's not a futile care issue. That's that you've done your job and these patients are now well enough to leave and you have nowhere to send them. I'm seeing a few nods suggesting that this is something people can relate to. So I think I've started to show you how beds and perhaps patient acuity start to become intertwined, right? If you have a lot of beds, you can admit patients of low acuity. If you have few beds, you can admit patients with only severe acuity. And we actually quantified this comparing patients in the US and UK, medical patients in about 200 different ICUs in each country. And this is just showing you the Apache 2 scores on the x-axis there, so higher means increased risk of death, and that's the distribution of the patients. So you can see, on average, in a relatively bed-constrained system, the UK admits much sicker patients. In the US, the severity of illness is about half that of patients in the UK on average. Now, even within the US, as I showed you earlier, you get a lot of variability in terms of acuity. And this is, again, work from the group in the University of Pennsylvania, where they looked at what they called deciles of ICU acuity, looking at how sick the overall unit was on any given day, and looking at the mortality for patients associated with being in a unit, not just based on your own severity of illness, but the severity of illness of everybody around you. And you can see we're pretty good at sort of flexing with this system. As the severity of illness goes up, that the standardized mortality ratio still crosses 1. There's no change in mortality until you get to those top deciles of severity, when kind of that feeling that the unit's going to explode because everybody is so sick. And you can see they're able to quantify that, in fact, that probably does have an impact on the mortality for those patients. We reach a point of extreme strain where it is impacting patient care. Now, what's very interesting, this is something that's probably not so relevant in terms of potentially different staffing models in this part of the world, but in the US, there are a lot of places that are closed ICUs, intensivist run, but there are also a lot of open ICUs. And so what they found, and I think this makes perfect sense, is that sense of strain, that impact of increasing mortality with increasing severity of illness was actually only present in closed ICUs. So this graph doesn't show you the mortality comparing patients cared for in open ICUs and closed ICUs. That's an important point. But what it does say is that if you're in an open ICU where you're a physician, you admit your 1 or 2 patients, you're taking care of those 1 or 2 patients, you're not affected by the severity of illness of the other patients in the ICU. But you close a unit, you have 1 team to care for everybody, and then suddenly, of course, it matters whether you're taking care of 10 post-op Whipples or 10 septic shock ARDS patients. They're all yours no matter what their problems are. And so it makes sense, again, that this would affect those closed units more. And this gets to staffing. And I think that this is a really kind of understudied area that we're starting to tease apart a little bit. And I think I've alluded to the fact of how staffing, therefore, may start to play a role in all of this. So there's been a little bit of work asking people who are particularly intensivists, at what point do you start to feel understrain yourself taking care of patients? This was a survey that was done where the first thing they just asked was, how many patients do you take care of on a given day in your ICU? And they found the average median mean was about sort of 13, 12 patients. And at night it doubled. Presumably they're sort of switching on and off, taking care of double the patients at night. And then they went on to ask, based on breaking the data up by if you worked in a unit where you tended to care for more or fewer than 14 patients, some of these questions. I feel stressed out from caring for too many patients. 30% of those working in units where they were caring for less than 14 patients felt stressed and answered yes, and 58% when they were caring for more than 14 patients. In terms of education, same thing. I have an adequate amount of time for teaching. 76% of the intensivists who were caring for patients in the smaller units, or small, on average, smaller number of patients, agreed, versus 39%. Now, this is survey data, right? So it's their perception of whether or not they feel that they're stressed or strained. And it's interesting, in the US, I've found that people really do kind of agree that 12 to 14 is the number that tends to resonate with people when you say, at what point do you start to feel stressed? I'd be interested to hear what people in this audience think later. But we started to look at this. So we used data not from the US, because it's quite hard to come by, but data from the UK, because they have really rich data across all of their ICUs, minus Scotland here. And the first thing we said was, how many patients on average are intensivists caring for? So this is only units where there's one intensivist. Because we said if you work in a unit with 2 or 3 intensivists, we can't really say who's caring for how many patients on a given day. But if there's one intensivist during the day, we know they're taking care of whoever's in the unit. And we quantified the number of patients you cared for between 8 and 4 p.m. every day as the number you rounded on plus the number you transferred out and the number you saw coming in. So it's a total of all of that. And we found the median across these ICUs was 8.5 patients per day per intensivist. But you can see there's also a very broad range from less than 5 up to almost 20, depending on the unit you're working in. We then asked the question, does the number of patients an intensivist is caring for on each day, averaged over a patient's day, does that make a difference to the hospital mortality for patients? And what we found was, in fact, there does seem to be a relationship. And we found a nadir at 7.5 patients per intensivist. And that big blue blob there is the 95% confidence intervals. That's telling you that we don't actually have good estimates much above that, mostly because we don't have that many units where the patient numbers were that high. So we have good estimates for that bottom part, but not so much for the top part. So just to unpack this for a moment, why does it maybe look like this? This is somewhat speculative, but what we think is probably going on is that there's kind of a volume-outcome relationship initially. You need to see enough patients on a day-to-day basis to have a unit that's sort of able to care comfortably for patients, that you've seen enough of it on a regular basis. At some point, though, you do get to this point where it's increasing strain. You have 7, 8 ARDS patients, you add one more to the mix, perhaps that's tipping you over the edge. And then there's this interesting plateau, and what we speculate might be going on here, I can get this to work, I'm stuck there. Ooh. Go back, sorry. Well, I'll just mention that so I don't get stuck on slides. What we think is happening with that plateau is that perhaps other mechanisms are starting to get put in place. When you're caring for 13, 14, 15 patients, that, now it's going on its own here, that perhaps you have other people around, you have more multidisciplinary teams, you have more residents and fellows. We don't have any of that data to explain that. And that's also what might shift that nadir. So to Americans, excuse me, a nadir of 7.5 seems very low. I showed you that people kind of split things at 12 to 14 patients. The patients in the UK are sicker on average. So one thing is the acuity, severity of illness of the patients you're caring for. Another might be whether you have residents and fellows. Maybe you can care comfortably for 16 patients. If you've got 2 really senior fellows working with you, not a problem. If it's you and 1 intern, then that might start to feel like a problem. So there's a lot that may shift this, as well as things like pharmacists, nurse practitioners, and other members of the team that can really make a difference. So just to end, one question, of course, is can we find ways to reduce strain without harming our patients? Now, one thing I would sort of urge against unless you're a very under-resourced setting where you have very few beds, that the general urge is to say, well, let's just build more ICU beds. I'm at 100% capacity, let's just build some more. This is a nice editorial by Jeremy Kahn and a colleague of his that goes into why this doesn't really work. It's kind of demand elasticity. If you build it, they will come. And you see this in the US. You build more ICU beds, you find patients to put in them. They kind of come out of the woodwork. It's kind of remarkable. And a great example of this is in traffic, where the more lanes of traffic you build, the more cars there are. And apparently this is not a parking lot. This is somewhere in China, an expressway that was actually built to be bigger and bigger and bigger. And the same thing's been done in Los Angeles, where they find that, more people buy cars, they stop taking public transport, and you just end up with the same gridlock you started with. So I don't think that that's really the solution for most places most of the time. What else can we do? Well, one issue is that we can think about silos. And what do I mean by that? I mean having lots of little units, a MICU and a surgical ICU and a cardiothoracic ICU. Now, sometimes that specialization may be helpful to you, but I just want to show you what happens. This is this issue of queuing theory. And each of these lines is an increasing, if you go up, chance of a delay in admission to a unit. In this case, this is work by Linda Green at Columbia. She was looking at maternity units, but it's the same thing. Someone pitches up, they're ready to have a baby. You can't say, sorry, I don't have a bed, come back tomorrow. You've got to be able to find a way to admit them without much delay. And what this graph shows you is that the likelihood of a delay is related both to the occupancy, which is what we tend to talk about, but also to the bed number. And so just to give you a sense of this, that occupancy and bed number are intertwined, if I say you've got a 4-bedded ICU running at 75% occupancy, you have 1 bed to admit someone to before you're full, and there's going to be a delay. If you've got 100 beds running at the same occupancy of 75%, you have 25 beds and can admit 25 patients before you're full. So you can't just talk in occupancy, and you can see lots of little ICUs become inefficient. You create more delays through that system. We did a little work looking actually maybe optimistically about how we function as physicians under strain, and actually we become more efficient. We were looking at all the patients who died in ICUs and asked, how fast did they die, depending on the strain? And what we found was that with more admissions per day, the highest there in the bottom, the less time patients were in the ICU before they died. And on the left there, the shorter the time to a new DNR being put in place. Similarly, if we looked at the census, the overall number of patients cared for, the higher the census, the shorter the time to death. And again, you see the same signal I showed you before, that closed ICUs, where there's one team that's aware of all of the patients and all of the stresses and strains, that's where you see this signal. And what you don't see is in an open unit. If you've got a cardiologist taking care of their 2 patients, they don't feel the strain around the other beds and the other patients. They're not going to rush their conversations. But we do clearly find ways when we need to change our care. Now remember, these are all patients who died, so it doesn't say anything about, we're not pulling the plug on people here, at least in this study. And then finally, I just want to mention something that maybe a teaser for my talk tomorrow, that the real model of flow here includes intermediate care, right? There's a lot of this that goes on. I haven't addressed it in talking about strain in the ICU. It's kind of a messy black box, which is why I've avoided it. I will talk about it tomorrow. And so that certainly can change things as well. So in conclusion, bed strain can occur at both a national and a local level. It's kind of all over the place. It includes the strain on staff, and I think that's something that we're only really just starting to think about. There are negative consequences, but it clearly can induce efficiency, and we really need to focus on those ways besides just increasing beds to decrease the bed strain that all of us experience. Thank you very much.
Thank you. That was fantastic. Really, really interesting presentation. Is there any questions from the audience? I have perhaps an obvious question. I think it's really great to get a broad perspective of what's going on with ICU bed strain, especially when we can be so absorbed in the details of our work on the floor. How can we use this information that you've presented to improve the care that we give to our patients and our patient flow in our own individual institutions and our own individual units?
Yeah, well, I mean, I think some of it is just awareness and recognition that you're working within a culture and a system where there are norms, and you're not going to magically change those norms in terms of who gets admitted and who doesn't. I do think that particularly around this issue of size of ICUs, willingness to perhaps loosen, for places that do have these specialized ICUs, thinking about ways to reduce those flow issues can be a big one at the local level. And then as we go forward, we don't actually right now have a lot of data about the number of patients we should all be caring for, but I think that's something that we should be starting to address in terms of physician burnout, not something I talked about at all, nurse burnout and nursing ratios, which is also not something I got to talk about. So all of those are things that certainly at the local level we can start thinking about trying to improve. What all those improvements are, don't yet know for you.
Okay. A question from the audience?
Hi, Joe Hyder from the United States. Thank you for a very nice talk. I think that in the ICU, we sometimes think that our job is to save lives. Maybe a different way to think about it is that our job is to decrease the hospital length of stay for all patients, whether they come to the ICU or not. To what extent is saying that we only admit the sickest patients a self-fulfilling prophecy where, let's say there's a patient who has an infection or early sepsis, and one opportunity would be to admit the patient to the ICU, hit all of their marks for septic resuscitation, send them to the floor and have them discharged. If there's ICU bed strain, the intensivist may see that patient on the floor and say, not ready yet. That patient may not get an optimal resuscitation. Then when they're in florid septic shock hours later, that's the right time to admit the patient to the unit. And then hospital length of stay may be greater globally. What can you say about the relationship between bed strain in the ICU and hospital length of stay globally?
That's a great question. I don't think that that's been looked at in quite that way of saying, are we, when we're in rescue mode as opposed to early identification mode, does that actually worsen things? I think that, it goes two ways. You admit someone early, they are going to have a longer ICU length of stay than if you admit someone 2 hours before they die. So there's a funny paradox when you look at deaths and resuscitation, because allowing someone to die generally shortens length of stay, as you pointed out. So I think it's very hard to tease apart that system, and of course every hospital is going to have different pressures, whether it's that their flow through the emergency room is the most important thing or running their cardiac ICU is the most important thing. But I think you raise a really important point, which is to say that just because someone has a low severity of illness on admission to ICU doesn't mean it's the wrong thing to admit them or that they shouldn't be there. And I thank you for sort of making that point that that's not necessarily the best marker. So certainly, I do think when we look at the UK data, some of what we see is that things like Apache 2 scores are maybe not representative of just how sick those patients were. And I say were because a lot of the resuscitation, at least when this work was done in sort of late 90s, early 2000s, some of that was being done on the ward because they couldn't get their patients to the ICU quickly, whereas in a lot of the US ICUs, they were able to zip them to the ICU and start that resuscitation process there. So a very complicated question without easy answers, so thank you.
We have a question that's come in on our app that I think is probably just worth addressing. It's from Dr. Clement Yan, who asks, with regards to staff as a factor, you've presented quite a lot of data on physicians, but of course there must be a lot of impact on this on nursing staff and other allied health staff as well. Yeah,
no, absolutely. It's a fascinating area, one that sort of is, I think, going to be talked about a lot more in the years to come. So there's certainly a lot of nursing data for on the wards, for surgical patients, less for in the ICU. I can tell you my personal theory is that there's a kind of, that it's a give and take. You can get away with fewer intensivists if you have 1-to-1 nurse-to-patient ratios. You need more doctors on the floor if you don't have that many nurses around, that it's probably a give and take. I think that also, of course, pharmacists have absolutely been shown and multidisciplinary teams have been shown to make a difference in terms of our outcomes for patients. And so there's a whole lot to unpack there, not to mention all the trainees and how they may come into play, whether hurting our patients or helping our patients, depending on who you ask. But I think it certainly, your day is very different depending on who's with you in what ICU you're working in.
Go ahead.
It's Michael O'Leary from Sydney. I'm going to make a sort of comment rather than a question, just to see what you think. So I work in a unit, it's got 52 beds and one of the larger units in Australia, and we have a very low threshold for admission. We believe that our job in the hospital is to basically provide a service to all of the other the other teams across the floors and make sure that we provide a rescue service. So we are very open to low intensity admissions. I would say in our unit we have around 30% ventilated patients, about the same as you showed for the US data. But the problem we have is the one you alluded to, is that I'm very happy to admit people, but I can't get them out at all. So I feel now I've completely lost control over the intensive care unit. I don't really determine who comes in, because I essentially let anyone be admitted, just on call, because I can't say no. And then I can't get them discharged. But I can't take it seriously. My colleagues say to me, oh, we're so busy. We're so busy. We've got 17 patients today. I don't know what to do.
Right.
I go around and they're all sitting out eating breakfast and reading the paper.
Right.
I can't
Yeah.
take it seriously.
Yeah, I call it the glasses sign. When they've got their glasses on, they're sitting in bed looking at you.
And then we do our SMR and it's really low and we say, God, we're doing a great job. What do you think? Do you think this is good value for money? Are we providing good value for money to the Australian taxpayer?
I think you've got the same problem that they have in most American ICUs. And I do think some of it is literally the ICU to ward bed ratios we've created. This issue of that we keep building ICU beds, whereas you do create efficiencies when you force a little bit of strain into the system. One paper I didn't show from Canada actually tracked patients on the wards when there were 0, 1, or 2 beds open in the ICU. And they found the same mortality, but they found many more end-of-life care discussions happening on the ward when they had to wait for a bed in the ICU, forcing that sort of efficiency of care into the system, even though it may have felt strained to people, because of course they're waiting for a bed that they want. I also worry, I think you've alluded to this issue, that we've basically de-skilled the wards, because we're now become the rescue for every single patient who coughs or spikes a fever, and I think that pendulum will start to swing back as people realize that we are spending a lot of time and a lot of intensivist and intensive care nursing time on patients who don't need those skills. As someone who trained in anesthesia and critical care, I am not the best person, to talk about their BPH and their hypertension control long term, which is what you end up doing when they're sitting in your ICU bed for 3 extra days. And so I think that is a problem in some systems, and I do think that good nursing care on the wards is one potential piece, although it doesn't fix the problem of literally not having ward beds. That's a whole other issue. Yeah, whole can of worms.
This is a really interesting topic, and I can tell from the number of questions that we're getting through on the app, particularly, for example, regarding management of bed strain in a viral pandemic, for example. But unfortunately, we are in fact out of time and need to go to lunch. So perhaps we'll have to continue these discussions outside of the room. But I'd like to give a very big round of thanks to Professor Hannah Wunsch for her talk.
Thank you very much.